So as we said, my name's Mindee, and I work with Dr. Brockmeyer. If you are one of those patients at Primary Children's who does telehealth visits, I'm sitting in the corner of the room. So when he looks to the left, it's me. But, oh no, not again. Thank you. We'll just log in so then it'll stop asking. As I said, I work with the spine program, so I work both in orthopedics and neurosurgery, and I see my own patients with scoliosis, back pain, that kind of stuff upstairs, and then support Dr. Brockmeyer down in neurosurgery and his patients. So I thank you, first of all, to all of you who came tonight. It's nice to see faces, and thank you for all of you who traveled so far to be here, and even those that traveled nearby as well. It's great for you to be here for this first meeting, and thank you for giving me the opportunity to speak. Dr. Brockmeyer asked me to talk about patient experience, so he just went through a big, long talk about the technicality and all of that stuff, so I'm going to touch a little more on your side of this. Now, keep in mind, I work at the pediatric hospital, so a lot of this is children oriented, okay? So just kind of to begin with, Dr. Brockmeyer already went through this a little bit, but Chiari malformation. So how did you get here? Like, what was your pathway to get here? Diagnosis. Reasons for ways that you're diagnosed, of course, headaches, MRI on headaches, scoliosis, neck pain, developmental delays, motor delays, swallow problems, speech issues, speech delay, sleep apnea, incidental findings. We do see a lot of incidental findings of this come through kids who are playing sports, they bonk their head, they do a CT, boom, you've got a Chiari. But they have no symptoms, no problems, and those are many of the kids that come in, see Dr. Brockmeyer, and then say, okay, we'll see you later if something comes up, right? As he said, about 2/3 to 3/4 of kids don't have surgery as they come through. And that's one of the things that, by the way, I find very admiring about Dr. Brockmeyer is that he's not jumping at the bit to do a surgery. He's very selective and wants to make sure he is going to help you. So, initial workup, a visit with Dr. Brockmeyer. So that's that initial workup where you come in and you talk to Dr. Brockmeyer and he goes through all of those things. He goes through the imaging. We get all the symptoms. We ask you all those questions. Are you having headaches? Where are they located? What causes them? What makes them worse? What makes them better? All of those things to find out if you have Chiari type headaches or if you have just migraine type headaches, because both are common, and so if they overlap, you want to be able to treat the correct problem. Many times you'll be sent to headache clinic if it sounds like they're migrainous, to at least get those under control so you can see if it's really Chiari type headaches that are happening, right? So as you go through all of that information, go through the imaging, and as Dr. Brockmeyer said as well, it's really not so much about the imaging as it is about your symptoms. And if your symptoms are appropriate, your imaging looks appropriate, he may consider surgery. But there's your options: observation, more imaging, because sometimes we need to get more imaging or more tests. So a sleep study, a swallow study, those kind of things. Or, are you a candidate at this point for surgery? So the decision making on those parts, what are your symptoms? Are they lifestyle limiting? And what are long-term outcomes, potential outcomes based on what's going on with you? Special consideration, scoliosis in the presence of Chiari and Syringomyelia. Dr. Brockmeyer talked about this a lot, but this is what I see upstairs in my clinic. And these images are actually one of my patients who I found, who I saw for scoliosis. She came in at the age of 10. She's not here today, or else I would see if she recognized her imaging. She came in at the age of 10. She had this left-sided curve. So this is looking from back to front. So left-sided curve, that was a C curve. As Dorothy alluded to, reflexes. We did the belly reflex, the superficial abdominal reflex. Do you guys all know what that is? Okay, so there is a reflex around the belly button, and if you stroke next to the belly button, it pulls to that side. If it is abnormal, it can actually tell you that there's a syrinx, that there's fluid in the spinal cord that's not supposed to be there. So if you have a patient who has an atypical curve, seems like it came up out of nowhere with the patient and their family, and they've got the asymmetric superficial abdominal reflex, that's a red flag for an MRI to see if what's happening, if there is something going on. It's not always 100% that there's a Chiari, but many times it's a really good indicator as to what's happening. This young lady, we got her MRI. You can see she's got a nice little Chiari happening up here with a little bit of Syringomyelia here in her in her spine, in her upper body, her cervical thoracic area. And she came, saw Dr. Brockmeyer, and he did surgery on her. She also has an idiopathic component for scoliosis. And so her curve, even though she was decompressed, continued progressing some, and she's been bracing for a while now. So she's one of those that we were hoping that as she was decompressed, it would improve her scoliosis. But because she had the other factor, it's not always 100% on that. Okay. So scoliosis, there you go. And Dr. Brockmeyer talked about that the studies show that if the kids are under 10 and the curves are under 35, that there's a really good chance that things will hold. I've seen that with kids over 10 and with curves under 32, that as soon as they've been decompressed, they stabilize. Sometimes if they're already bracing, it actually improves the curve as the kids grow. So say that this is kind of the surgery overall for our kids here at primary. So you've decided that we're going to have surgery. This is kind of what it looks like for the kids. Surgery day, pre-op at Primary Children's. This is kind of our pre-op room. The kids come in, they meet the anesthesiologist, they meet the child life specialist. Our child life specialists here are amazing, especially with the little kids. They do what they can to make them comfortable, to play with them, to try to make the kids feel like they're doing, that they're there and that things are okay. Many times as parents, our anxiety pushes off onto the kids, right? And it's still kids that are old enough to understand what's going on, they still have their anxiety. Trevor, did Dr. Brockmeyer make you a deal? Do you remember? Can't remember. Dr. Brockmeyer is great about this. Many times with the kids when in office, when he can look at them and see that they're nervous, he will say to them, I'll make you a deal. I'll do all the worrying for you and your parents. And your job is just to get better. And that is so fantastic because kids, okay, I'll do that. So it's fantastic. And our child life specialists are wonderful when they're in the pre-op area. Then anesthesia, you go to sleep, anesthesia, you get the good stuff. But not only is it the good stuff because you go to sleep, but you've already worked with child life and they've given you different smells so that you have a really cool mask that they can put on you and you pick how you go to sleep. Once the surgery is done, you get to go to the NTU. This is an NTU room. NTU rooms here are really awesome too. They've got like an Xbox or PlayStations in them so the kids get to play. They can have fun in there. The parents can stay all night, every night, in this fun little bed that you can't see. This non-comfortable little bed here in the room. It pushes out. The chair kind of lays back a little bit and the couch lays out. But yeah, if you ever end up in the hospital again with your kids, bring your own pillows, bring your own blankets, because we know that things are not comfortable here. I think sometimes they do that just to make sure parents go home and do a little self-care as well if possible. So once kids are feeling better, and usually it's about 3 to 5 days that the kids are here in the hospital, they get to go home, but we'll talk about things they can do, right? Usually, like by the next day, kids are up and walking around, they're moving around. There's lots of stuff to do here in this hospital. There's the playroom for our older kids. We've got the teen room, right? Because we don't want the big kids going in and coloring because they don't want to do that either. And if you are musically inclined, we have Sophie's room, which is our music therapy room. That one's pretty cool too. You can go in, you can play some instruments, you can listen to people playing music. It's actually a really neat room. And for the parents, we of course have the Ronald McDonald room, where parents can go in and have a little bit of respite, even if it's just a nap, a shower, food, all of that. So our parents are taken care of typically here at primary. We do our best. If you guys have surgery again, come over to primary. Like it's a different world. So that's kind of the amenities we have here for the kids. So post-op course, typical post-op course. Of course, the goal is to keep post-op pain under control with IV and oral meds. Many times the kids will have IV, like ibuprofen, so the ketorolac or the Toradol, and then they have narcotics for breakthrough pain. Some kids, or most kids, experience nausea for a couple of days after the surgery because where that surgery is, you're in the area where there's the nausea center. But that can usually be managed with medications. And once you're feeling well, you're able to go home. It's always nicer at home, we know that, but Primary Children's has pretty good room service. The menu's usually pretty awesome. So once you go home, from there, your only job is to rest and get better. Most kids are back to school within about 2 weeks and back to more normal activities within a month. So this is kind of the typical expectation, what we want to see with our patients, right? But sometimes things don't go as we planned. There's always the risk of minor complications. Those include infection in the incision, chemical meningitis, CSF leaking, or the pseudomeningeal. If the medical team does its best to diagnose these complications early and treat them appropriately, of course, with infection in the incision, antibiotics to try to help take care of that. Chemical meningitis, kids could have like headaches for a few days, like even weeks after. But with a dose of steroids or a round of steroids, many times that improves over time. And then the CSF leak, sometimes it requires a resurgery. Right now they're using a lot of Diamox with the kids to try to prevent a re-op for that. But so they're doing their best to try to diagnose this and treat as quickly as possible. So post-op follow-up. We see most kids or most patients back in clinic within about 6 weeks of surgery. At this time, Dr. Brockmeyer is able to see you, find out how you're doing, see if your symptoms have resolved, look at the incision, see if there's anything concerning. And further follow-up. If you're doing well at your post-op visit, then most likely we'll see you in a year to make sure everything looks good, usually with new imaging. If you're having complications, Dr. Brockmeyer always wants to see you sooner than that. And if you have a syrinx, you'd plan to get a new MRI 3 months after surgery to make sure it's starting to resolve, to evaluate the surgery itself. So now what? Okay, am I done with Chiari? My surgery's done, right? Am I done? Most of the time, yes. Once the surgery is successful and there's evidence that fluid is flowing normally, you should not have to worry so much about Chiari anymore. And another thing that I love hearing Dr. Brockmeyer say to his patients, put it in the back of your head, right? Love that. So, but sometimes kids continue to have headaches. If this is the case, Dr. Brockmeyer tries to figure out if you need another operation or consultation with the headache clinic, which is neurology here at Primary. Sometimes other symptoms do not improve, so further follow-up course is based on the symptoms and depends on the child or patient. Because sometimes you've got to say, okay, we did this, it should have resolved. Is there something we're missing? Is there another direction we need to look? And even with that, sometimes things still don't go as planned. And as Dr. Brockmeyer talked about with the cervical instability, some kids may even need to try a trial of wearing a cervical collar to see if their continued symptoms are related to that bone position, that cervical kyphosis, and potentially ultimately undergo another surgery. That's the fusion. Is there scarring in there that's now preventing you from having normal flow? Do you need a stent? These things can happen, but are not the typical experience. And as, again, Dr. Brockmeyer said in his presentation, most of the time with those are more the Chiari 1.5 patients. That's more often. The simple Chiari ones, you don't see that as much. It is very important to understand that everyone's experience is different and everyone is treated as an individual. So I can make all of these generalizations of this is how we would expect it to go, but your pathway and journey is going to be your journey, no matter what. So if you didn't fit into this typical pathway that I was talking about, that's no surprise because you are you, and this is a generalization. Finally, activity after decompression. Activity after the surgery is completed and the area is healed, typically within 4 to 8 weeks, you can return to regular activities. Now, Dr. Brockmeyer warns of 3 activities to avoid: bull riding, bungee jumping, and the most dangerous, of course, boy or girl chasing. That's it. Any questions for me? Just giving you the overhaul of the kids. Thank you.